welcome to episode 5 Hair on Air podcast. Thank you all for all support that I'm getting and for interesting topics that you're suggesting that I certainly am going to cover in one of the next episodes. Now it's time to talk about female hair loss, and this is going to be the first in a list of series that we're going to be discussing hair loss in women. I have really great pleasure to host my first female guest, a doctor and a colleague that I highly respect and look up to, Nicole Rogers. Nicole graduated from Harvard University with honors, and then she went to medical school to Tulane University, where she serves as assistant professor at Department of Dermatology. She is a fellowship trained hair restoration surgeon and also a board certified dermatologist. Nicole publishes on a regular basis. She presents her work on different meetings of different societies, and she's a member of a variety of hair restoration societies, including the Psychotricial Foundation Research Society. So today I'm welcoming Nicole. Welcome to Hair on Air.
Well, thank you, Dr. Kuka-Epstein. It's a pleasure to be here with you, and the feeling is mutual. I have so much respect for you and all of your achievements, and it's just such a pleasure to share this platform with you. So thank you for the invitation.
You are most welcome. I have to be honest with you. Part of me wanting you to be my female guest is that maybe you can help me with current condition that I have that we are going to be talking about today, and I'd like to pick up your mind. How would you help some female patients going through what I'm going currently? But so let's talk about female hair loss. How often do you see women in your office losing hair?
Pretty much every day, multiple times per day. And it's very distressing, no matter what, no matter whether it's a young woman who is in her early teens, or, we have women who are in their 80s and their 90s who are noticing hair thinning or hair loss. So, I think it is distressing to women of any age and any part of the country, probably any place in the world, where this is happening.
Yes. I read, I started as a hair transplant surgeon, and then I slowly shifted to hair loss therapist, and I am surprised how many women are dealing with hair loss of different etiology. And it is definitely, per definition, it says 40% of women at the age of 40 suffer from hair loss, which is a huge number.
Exactly, it is. And I think it's sort of the involuntary component to it that's so distressing. Some women, when they come in, they have an idea of why they think it's happening. But I think for a lot of women, they just don't know. They're just not sure. And so they're really looking to us for guidance, for, reassurance, maybe to tell them, okay, this is just temporary. You're going to get through this. In fact, I think the majority of women are hoping that we will give them, some reassurance that, this is just a weird one-time thing and that it's going to stop. And so, sometimes the hardest part is figuring out, is this in fact temporary, or could it be early female pattern thinning? And I know that's going to be a topic for another day, but, sometimes that is part of the mystery of unraveling the difference between those two.
Yeah, we're gonna discuss it definitely today, because many of them think there is only one type of hair loss, and in reality we have a list of hair loss that we diagnose and treat in a different manner. So that's why the essence is a good diagnosis to begin with, and then we know we can name the condition and treat it. I would like to focus today on active shedding. So when a female patient comes to you and she says she's actively shedding, she's losing a lot of hair, where your mind goes then? What do you start thinking that the reason is?
Right. So part of our intake process is that we, basically ask our patients to tell us their story. And usually there's a component of when did the shedding begin, and so was it in the last 3 months, 6 months, 1 year? And then we like to ask them what other major events are going on in their life, So the question being, was there a major physiologic stressor? Okay. And, here in New Orleans, obviously, we're always stressed by things like hurricanes and flooding and that kind of thing. But, the bigger issue is, did you have a baby recently? Because we know, for instance, that childbirth is the most common cause of telogen effluvium, which is the temporary shedding. And part of the reason for that is that the hairs, while a woman is pregnant during those 9 months, they go into a suspended resting phase. And so what happens is that all the hairs that they should have shed during that 9-month period, they actually hold on to. So their hair looks thick and beautiful and lovely during the entirety of their pregnancy. But then unfortunately, it all sort of sheds at once, usually 3 to 6 months after that baby is born. So it can be, very distressing. And I think, as we talk about it more, I think women are better prepared for that to happen. And I don't think they panic quite so much after the fact. But, I think that, for women who come in asking, how can I prevent this? It's still kind of hard for us to really say, oh, sure, just take this vitamin or use minoxidil. I don't think there's really any good way to actually prevent it from happening.
Yep. It is funny that you said this, but I do educate my patients about, possibility of shedding after pregnancy. And I myself am a hair doctor, and I'm currently shedding because I had a baby 4.5 months ago. And it's really a distressing thing in my life because I have great hair, and now it's just shedding and shedding and shedding, and I'm leaving layers of hair. You can, from a personal experience, you cannot get yourself ready for that. You can't. Absolutely. Apart from pregnancy, what are other possible triggers of telogen effluvium, the condition that we call this acute shedding?
Right. So probably next on the list is very severe illnesses. So for instance, people who undergo, maybe they had a high fever, maybe they had a prolonged illness. COVID has been in the news a lot recently as a cause of major physiologic stressor. And there have been numerous reports in the medical literature of patients who developed massive hair shedding. And it's usually that same timeline, approximately 3 to 6 months after that, major illness. The other things that we see are rapid weight loss. So the building that we're in, we have a bariatric clinic upstairs. And it's kind of funny because we'll have patients who, maybe get a procedure done to limit their food intake, and they may drop 80 pounds over, just a few short months. And so, it's not uncommon for us to see patients who have developed massive hair shedding from that situation.
I tell them, you lose weight, you lose hair.
Right, exactly. I mean, you like to think that if it's done in a very slow, controlled fashion, that they won't have hair loss, but I don't know. You tell me your experience. I feel like even when it's sort of slow and controlled, still people can have some hair loss.
Mine is too. I always stress out what type of diet are they doing, because they have to be covered with a good intake of protein to control iron, ferritin, vitamin D level, have good supplementation, not just vitamins, but minerals. I found very important that they're low in zinc, low in magnesium. Some have high metals in their body. So I feel they're taking that weight loss lightly. That really has to be planned. carefully so they don't face this issue with hair.
Once in a while, there are cases of, obviously what we call chronic telogen effluvium, where, young women who maybe are anorexic or bulimic, they are so thin, and, we fuss at them because they come in and they're chronically having their hair coming out, their hair is shedding. And, sometimes for those women, the only real way to get that addressed is to actually put some weight on.
Yep. What about, have you seen the connection between certain medications and telogen effluvium?
Well, it's interesting because if you look back, decades in the medical literature, you'll see that there's a link with numerous cardiovascular medications such as warfarin. Certain beta blockers have been linked, and certain other antihypertensive medications. And the thing that's interesting, if you actually dig a little bit deeper, you'll notice that there's a correlation between the same people who are genetically prone to hair loss and also genetically prone to cardiovascular disease. So I'm not always totally convinced about that link with cardiovascular drugs because I think there may be a little bit of a confounding factor. I think, those are actually people who have maybe early male or female pattern hair loss who are possibly pinning it on that, blood pressure medication. But those reports do exist in the medical literature. And I've also seen a link with a particular statin medication. So even high cholesterol drugs, could cause it. The thing I tell my patients is that almost any medication can have almost any side effect, and so often, if they look in the list of side effects for that package insert for that drug, they'll see alopecia.
Yes.
Before I focused on hair loss, I did a lot of general dermatology, and we would prescribe a lot of Accutane. And Accutane, which is a vitamin A derivative, has been linked in the medical literature with temporary hair shedding. But I tell you, I didn't really see it that often. I know it's been reported. I kind of wonder if maybe it's something that we see in people who are genetically prone to develop male or female pattern hair loss later anyway. Could it possibly unmask a male or female pattern hair loss? But I never really saw that many cases of frank hair shedding as a result of Accutane usage.
Mm-hmm. Yeah, as you said at the beginning of the conversation, some patients know what is causing hair loss and some have no clue. But when you take a detailed medical history and you tell them, you're taking AC inhibitor, this could be one of the reasons why you're losing hair. Then they have an aha moment. I never thought of that. And also, for example, patients with thyroid issues, we know those can have hair loss, but also medications for thyroid hypothyroidism can cause hair loss. So we can't tell them to stop medications, obviously, for another reason, but just the awareness that that's a contributing factor to chronic telogen effluvium, probably.
And actually, just to follow up with what you were just saying about thyroid, I feel like that can be such a muddy, murky area. Because, I like seeing patients, in a perfect world, they're, seeing a board certified endocrinologist who's regularly checking their thyroid every 6 months and who's using a drug like Synthroid, which is very accurate and specific and good at controlling, strictly controlling the thyroid function. Because where I go off the rails sometimes is with patients who maybe are seeing, doctors who are using desiccated pig thyroid and they don't get as tight a control over their thyroid function. And then especially if they're not checking their thyroid on a regular basis. The other thing that can alter thyroid test results is if they're supplementing with biotin. The FDA had issued that warning a few years ago that high dose biotin supplementation, which unfortunately everybody wants to take the minute they get hair loss, will alter thyroid test results. And so patients have to get off the biotin, preferably for a week before they get any kind of thyroid testing done in order to get an accurate outcome.
Yeah. What is that with biotin? Because I read not recently, a few months back, publication about vitamins for hair loss, and even that publication said there is no relevant clinical study that says that biotin helps with hair loss. But every single patient, when I mention, are you taking any supplementation? Of course I'm taking biotin, tons of biotin. What is your opinion the same?
Yeah, I mean, I've seen some old studies showing that, infants, right, who were biotin deficient or whose bodies were unable to manufacture biotin could develop some hair loss. But how that spawned into this sort of like widely held, like strong belief that biotin will help you regrow your hair, I have no idea. And so, yeah, it drives me crazy. Sounds like it drives both of us crazy.
Obviously, but everyone, even when I do topical compounding lotion, my patients are, please put some biotin in there. I'm like, but why? No, and you can't fight it. It's hard to fight it.
Right, I know.
So what I wanted to, if you can explain to those who are listening, what is happening when patient is coming and shedding actively? What's physiologically happening in the hair cycle?
Sure. So, the hair cycle is so complicated, and there's, so many different signaling mechanisms and cytokines, and, I would be lying if I admitted to understanding every little aspect of the hair growth cycle. But, my best understanding is that the hair has finished the actively growing phase, or its growth phase has been cut short by some major stressor like we talked about. And so the hairs, at least with telogen effluvium, are just kind of waiting until it's time to come out, or they're being pushed out by new hairs that are replacing them. There's also what's called anagen effluvium, which is where people receive a chemotherapeutic drug which acutely, abruptly cuts short the hair follicle growth cycle and the hairs actually come out at the same time. So that's a little bit different from the telogen effluvium. Telogen effluvium always has this, 3-month time lag that, makes it a little bit harder. I always tell my patients it's kind of like driving a big ship down the Mississippi River. Here we are in New Orleans. So, they understand that concept that like it just takes time. Whatever change has happened a while ago, we're just now seeing the effects of it, several months later. And so we really have to think and investigate, what happened in the past and how we can, resolve that or correct that.
Yeah. It really became popular during last year of COVID when patients started shedding after COVID. And that's when we in hair community started discussing more as a new symptom of COVID is hair loss, which happens exactly in that time frame you're talking about. So how does a patient present to you? She comes to the office, and typically what I'm doing right now, and this is what I'm telling all my patients not to do, but I'm doing this all the time, just pulling my tail and like counting hairs. And I tell my patients, please do not focus, just move your mind of it, but I'm doing it too. So besides doing that all the time, how do you clinically define telogen effluvium? Is there something that patient can look on their hair for and say, okay, it could be a telogen effluvium?
Well, what you're describing, pulling the ponytail, that actually is something that we use as an examination criteria, right? It's called the pull test.
Yes.
And it's, basically where we grab a grouping of usually between 5 and 10 hairs, and we just pull very kind of firmly and gently away from the scalp, and then we want to count how many of those, come out in our hand.
Yes.
I think it's important to differentiate between telogen effluvium and breakage, because so many women nowadays are really over processing their hair. And it's usually a combination of things like either chemical relaxers, heat, flat irons, and also highlights, So in women of Caucasian ancestry, it seems like we're seeing a lot of what seems like telogen effluvium on the initial presentation. They say, "Doc, my hair's coming out. It's everywhere. It's all over my bathroom floor," and then on closer inspection, wow, they have, tons of hairs that are breaking off at different levels, going anywhere from close to the scalp to the bottom of their hair.
Yeah.
So when we do the initial examination, I use a lot of dermoscopy, where we're looking under high-power microscope at the scalp, and we're assessing. And usually with classic telogen effluvium, the hair shaft diameter is the same. It's uniform across the board, right? Because the hairs are just entering a resting phase and they're coming out. Sometimes you can see short regrowing hairs, and that is usually when the telogen effluvium is starting to get into the recovery phase. But sometimes you don't see that at the very beginning, so it's not necessarily a marker for sure. With early female pattern hair loss, there's more variation in the hair caliber. So,
yes.
And those patients can present with telogen effluvium, but in the context of early female pattern hair loss. So, they may have a massive positive pull test when you yank on the hairs, but then when you look at them dermatoscopically, you're still going to see that variation in hair caliber, which points toward early miniaturization. And those patients are usually also going to have a family history of hair loss. So, you can spend a long time, talking about thyroid and hormones and medications. And, if you ask them early on in the interview, about their family history, I think sometimes it can save you a lot of time, because they may say, "Oh, my twin sister wears a wig," or "My dad was bald," or, "My brother shaves his head," or, And sometimes I think it kind of helps you arrive at that diagnosis of female pattern hair loss a little bit earlier.
It is so critical that discussion with the patient, because and our female patients should know that just to be asked the right questions, because not every hair loss is the same. There is so many variation of it, and so many factors that can contribute. That's why it shouldn't be taken so lightly. My consultation for women is so much different than a consultation for a male patient, because this is really putting all the pieces of a puzzle together. And I love it because it's not easy. It's not. And the treatment sometimes, in many cases, not easy, but we're going to talk about that. But just to find the reason why one is losing hair, it's interesting. Do you look like, so when we have androgenic alopecia, there is some sort of hair appearance that we kind of recognize, and we can tell, okay, this is most likely androgenic alopecia. How about for telogen effluvium? Do you look for signs like frontotemporal recessions? Do you measure the girth of the ponytail, or is there anything that you search for? Or no?
Well, like I said, if I see fairly uniform caliber of hairs on dermoscopy, and especially if I see those short regrowing hairs, they may just be a few millimeters long, then that's usually a pretty good indicator. But sometimes you have to do a scalp biopsy, and we do that here in the office. It usually takes about 5 or 10 minutes. We use a little lidocaine just to, gently anesthetize the part of the scalp that we're going to sample. And then we use a little 4-millimeter punch. It's basically like this, or like this. It's about this big. So we just sample a little piece of hair-bearing scalp. And then we just put a suture in there just to bring the skin edge together. And we send that specimen to the pathologist. And they're able to look very carefully under the microscope, and they can actually count the ratio terminal to vellus hairs, so thick hairs to finer hairs. And then they can sometimes also look at the height, the length and the depth of the follicles in order to see if more of them are actually in the telogen or resting phase.
Yes. And I bet you have a good pathologist, because that's also a critical link, to have a good pathologist who's going to read the result well. And also it could be a combination of, for example, a woman suffering for years of androgenic alopecia and then experience shedding. So it could be a combination of the two.
Right. And it's frequently a combination.
It is.
Because what we didn't even really talk about is, the various types of scalp dermatitis that can complicate the picture. So, if a woman is also prone to, say, psoriasis, she may present with diffuse, dry, flaking, scaling, either throughout the entire scalp, or sometimes it's more just in the occipital distribution, and if it's really uncontrolled, that can also cause hair loss. Sometimes my pathologist will use the term psoriatic alopecia to describe, shedding in the context of this uncontrolled dermatitis. Sebopsoriasis, that's kind of a combination between seborrheic dermatitis and psoriasis. That can also result in diffuse hair shedding if it's not well controlled, because there's just so much inflammation there. And then obviously, the cicatricial alopecias like lichen planopilaris and frontal fibrosing alopecia, and in our women of African descent, central centrifugal cicatricial alopecia, those can also present with hair shedding in the early stages because they haven't been addressed. They're not getting any medical therapy for that underlying inflammation. So of course they're having massive hair shedding.
Yep. Yeah, I say the essence, the basis of healthy hair is healthy scalp. To begin with. Sometimes I put the dermoscope and I see the scalp is burning of inflammation. And when a patient said that she has been seen by someone for her hair loss, and I ask if dermoscopy has been done, and she says no, and then I say, well, you haven't really been seen for your hair loss, because I said the dermoscope is stethoscope for us. It is. It tells us so much.
It does, and it's nice because it's non-invasive, but I think it's still up to the eye of the beholder. I think even if you own a dermatoscope, you still kind of have you need a little bit of experience in terms of knowing what you're looking at. And I think the same is true with a pathologist, like a dermatopathologist, because I had a young woman recently who she had a biopsy that showed telogen effluvium, but then when I looked at her under dermoscopy and I saw a lot of miniaturized hairs and I found out she had a family history of hair loss, I said, I think you probably have early female pattern hair loss. And she wanted me to repeat the biopsy to prove that. And, and I tried to explain to her, it all depends on who read the pathology, and I was happy to redo the biopsy, but sometimes you have to kind of go with the most accurate indicators.
Yep. And also looking into the lab results. So to do a hormonal panel and to look into markers of inflammation possibly, and also to vitamins and minerals in the body to see if they're within range. So I guess all your patients need to present with their labs, right?
So it's interesting because, we do a pretty comprehensive reproductive history on women. So first, we just want to know, do you still have your lady parts, right? And if they're premenopausal, we presume they're still menstruating. Are their periods very heavy, or are they on, say, birth control that, shortens or lightens their period? And so if we know that they're having heavy menses, then, obviously we're going to be very concerned about things like ferritin, which is a measure of the body's iron stores. Likewise, you mentioned hormones. if they're starting or stopping birth control. I also like to find out what birth control they're taking because, every birth control usually has ethinyl estradiol as the estrogen component, but then the progestin, depending on which choice, can have a more or less androgenic component. And so the birth controls that have things like norethindrone in them, they have that stronger androgenic component. So I try to steer women who maybe have a tendency toward hair thinning to more birth controls that have such as, and I'm not particularly endorsing the brand name, but any generics are fine, either Yaz or Yasmin, because it has drospirenone, which has no androgenicity to it at all. So it's the safest for the hair.
This is so important, and I wanted to thank you because I picked that up from you and your presentation in Bangkok, because female patients do take birth control pills and they necessarily blame them for hair loss, but you just said not all of them are in that group of high risk birth control pills causing hair loss. So I've learned that from you to ask them which birth control pill they're taking, so I can guide them to switch or not me, but to speak to their OB. And also birth control pills do cause hair loss after patients stop them, which is and also another cause of shedding. What else do you look in the labs of patients?
Well, so I'm still kind of going along the hormone line that we were just talking about. There's been a ton of women recently who I've seen, they're getting these testosterone injections and they're getting them like say as pellets, and they're being given them for sex drive and energy, and these women, they love being on these testosterone pellets. But the problem is they're developing massive hair loss from them. And so that's been another major source of telogen effluvium, is these women who are taking testosterone supplementation. And, I do my best to educate them and try and say, please, if you can get off of this, that would be the best thing. But, so many of the women, they just love the way they feel on it. And they're like, no. So that's tough.
Yeah. To weigh what means more to them.
Right. Exactly. Let's see. You were asking about other lab values. Is that right?
Yeah. Vitamin D.
Yeah. Oh, for sure. So, the normal cutoff is 30.
Have you seen a normal value of vitamin D in your female patient recently?
A lot of women, I guess maybe because their doctors are worried about osteoporosis, a lot of my postmenopausal women have totally normal vitamin D, and actually sometimes it's like in the 50s or 60s, because their primary doctor or their OB has them on some kind of vitamin D calcium supplement already. But it's my premenopausal females and my women of African descent who will often have low vitamin D levels. And
interesting.
Yes. And so, those are the ones who we try to get supplemented with vitamin D. What else? Let's see. Zinc, that's shown up in the literature. I find with COVID, more of my patients are taking zinc just proactively because they've heard it can help prevent infection. So I haven't seen as many like low levels of zinc, but, I think it's sort of one of those things, if we can get those levels propped up a little bit, and they can just take zinc over the counter anywhere from 30 to 50 milligrams. But I do recommend that they take it with food. It can make them a little bit nauseous if they try and take it on an empty stomach.
Yep.
So
I think these are the main ones as well. I can't think of any other.
Do you check an ANA in a lot of your patients?
I have a basic analysis and like extended. So I do NAA like as extended panel when I add all the micronutrients. I do B12 vitamin B12 as well, but not if I think it's necessary. I on a regular, like a basic panel, I don't. I do hormones, I do thyroid hormones, I do like inflammation markers like CBC, and I do vitamin D, ferritin, and iron levels. That's like my basic panel. But then I go into extended when I want to add NAA. So Nicole, I come to you and I said, listen, I had a baby. This thing with my hair doesn't stop. I don't have a family history of hair loss. I had always had a great hair loss. And what would you tell me to do right now? So.
Well, I would probably just say, give it a tincture of time and, just try to be patient, just trust in the process. You will get your hair back. It's just a matter of time. And, but to, probably manage my patient's expectations that it can take a good 9 to 12 months, for that hair to really get back to maybe where it was before, or longer even. It just depends on, I guess, how long they like to keep their hair, and so what their idea of full length is. That might vary from person to person.
Yeah, I always think that there is a fine line that I'm always trying to find when to intervene, when not to intervene in terms of hair therapy for telogen effluvium. Because by definition, it should resolve on its own. Tell me I'm right.
I think the other thing that we do that is reassuring to our patients is we say, come back and see us in another 3 to 6 months. And then that way they know that they have an appointment out there in the future, such that if the hair shedding has not resolved, then, we're going to talk about it and we're going to do a little bit deeper digging if we need to, or we're going to talk about maybe doing some kind of medical therapy to help them maybe stop the shedding, or maybe we'll even do a biopsy, because they may say, well, it's still shedding and now it's kind of tender. Could it be an early evolving cicatricial alopecia? And so it may be worth doing a little bit more workup. I think a lot of times where people get frustrated is they feel like they get dismissed too easily. And like you said, because telogen effluvium does sometimes run with other forms of alopecia, we just have to always be on the lookout for that. And, we have to tell our patients, I had a dermatology colleague, he used this expression that sometimes it's like a Polaroid picture, it takes a little time for the actual, grains of the image to like come together and so that, we can actually tell what's exactly happening. But it takes time.
And if you are to suggest therapy, what are those that you would use, and if there are some that you wouldn't, what would those be?
Well, the only medical therapy that is FDA approved for female pattern hair loss is topical minoxidil. The problem is that it's not approved during pregnancy or lactation, and so to avoid the risk of having, say, furry babies, I would probably tell my females not to try and incorporate that until they were, say, done, breastfeeding at least. But, something like low-level light therapy, which is FDA cleared as a medical device, that is very safe in pregnancy. And, I don't know why they couldn't use it also during breastfeeding. I think it would be fine, to use something like that to...
I'll tell you, it's just fine.
Have you been using it?
I just started, yes.
Okay.
So I started my natural vitamin course because of the reasons you're telling me, I can't do anything because of the baby, but I did started vitamins and laser. That's what I decided to do. So we'll see.
Well, I hope your shedding slows down soon. For your part, for your hair part and for your sanity, more importantly.
Yeah. Is there any therapy that you wouldn't use? I'm asking you because this is my opinion. I see that scalp that is actively shedding as a volcano. Like, I am so opposed to anything invasive on the scalp during the active shedding, because you don't know what's gonna be the outcome of the therapy. That's why I'm concerned to inject anything, to be honest with you, during the active phase of shedding. I'm more like you. I would go with the lotion to slow it down, to stabilize it, and then maybe start injecting. What are your thoughts about that?
Well, it's funny. I feel like a lot of our, some of the doctors, the dermatologists who, came before me and who have trained me over the years, they have historically used intralesional triamcinolone injections, either for hair shedding or for female pattern hair loss. And just in looking at the literature, I've never seen any data to really support that. But I think if you're also possibly suspecting, an early inflammatory process, I think sometimes it's worth a try. Maybe not using steroid injections, but sometimes I'll recommend like clobetasol shampoo, if they maybe have some trace inflammatory process going on. And then, they may say, oh, yes, it helped. Or they may say, no, it doesn't. I mean, it's kind of a gamble. I don't really think anything that we recommend is necessarily going to work.
Yeah. Yeah. What do you think of doing PRP for hair loss in that active phase?
I mean, I have not seen it work to help really slow down the hair shedding. I really don't even recommend it, just because, I just don't really feel like that's the right treatment.
I'm just asking you because for some reason a lot of my female patients, they see the holy grail in PRP therapy that's gonna just do wonders, but it doesn't happen, and they keep injecting it, and many of those PRPs have pro-inflammatory effect, which can worsen the condition. It's not just pure platelets and let's inject it, but there is impurity there, and many comes with neutrophils that's going to worsen the condition, and they don't know that. That's why I'm glad we share the view how that's not the rescue plan.
Yeah. Now, I know, Dr. Kuka-Epstein, that you do a lot with fat research, and have you ever seen any data showing that there's a role in using fat cells to possibly treat telogen effluvium?
I never dared, because injections are so invasive. And I never dared. Maybe I should, but I was just concerned that it's too invasive to inject, because it's not like PRP is injected with the needles. This is cannulas that I go under the surface of the scalp, and I just thought it was too invasive, so I haven't really tried.
You know where would probably be an interesting area, and this could be a future research project for, I guess, any ambitious dermatology resident, is looking at cold cap technology. You know how they're using that for, preventing hair loss due to chemotherapy, like the antigen effluvium. Maybe that's something that pregnant women could use, like shortly after delivery. I don't know.
Yeah. Well, I know. When we were getting ready for this interview, I shared with you that shedding after a girl is heavier than shedding after having a boy, at least in my case. So that's going to be my next study. I'm going to retrospectively interview my patients to see whether that girl takes more hair out of her mother than boys. So we'll see.
And then you have to look at the amount of hair lost on the father, because sometimes you may lose the hair at the beginning, but he may lose the hair. He may lose more of his hair later as she becomes a teenager and starts dating. You never know.
That's a good point. We'll see. Maybe at the end we're gonna be even in the amount of hair loss that we're
And
gonna
especially if
experience.
she's as beautiful as you are, he's going to have a lot of headaches.
I have a good friend with 2 daughters who told me that once her daughters enter teenage years, he's gonna put brace on them, on their teeth, so that's gonna keep the boys away. I don't know if that's gonna work, at least for a year or 2. I'd like to thank you for this conversation. I thoroughly enjoyed it, and I know our listeners are going to enjoy it as well and learn a lot what to do and how a consultation for female hair loss should look like. And many doctors, of course, will hear valuable information. So thank you so much for your time on a Saturday. To be able to join us on Hair on Air.
Well, the pleasure was all mine. Thank you so much for this invitation.
Thank you, Nicole.